First of all, thanks everybody for coming. It's nice to see some old faces that I've seen before and some new faces as well. So thanks everybody for coming. I'm Dr. Ken Doolittle, for those of you that don't know me. And what we're going to talk about tonight is osteoarthritis and joint health and where we are in 2022. We've definitely made a lot of progress over the past 30 years, even the last 10 years. And so that's what we're going to just talk about tonight. Just by way of just some housekeeping, restrooms are around the corner this way. There's refreshments by the kitchen, and I have some handouts over here by the table there for people that are interested in more than what was just at the front desk. What we want to talk about tonight, we have developed a program here at Knox Community Hospital, and we're actually accredited by the Center for Medicare and Medicaid Services, or CMS. Medicare has a Center of Excellence for total hip and total knee replacement, and that's what we want to go over tonight. And what are the components of it, and how do we structure our program? But I brought up this in the front room here. These are our most recent certifications. We were actually certified as a Center of Excellence in 2015, and we've been recertified 3 times, and we'll be recertified again next year in 2023. It'll be our 4th time. So we have a group of people who have worked hard to maintain our certification, and so there's a lot of people in the background, more than just myself. It's a team effort. What the program affects, there's multiple components to it. First of all is a preoperative education class. We call it prehabilitation to prepare everybody for their total hip or total knee replacement. We have actually a joint class that we go to. We have specialized surgical care with, as I mentioned, a team approach. We minimize our soft tissue trauma. We use biological healing techniques that we'll go over, nutritional support, and then our postoperative rehabilitation. The easy part's having the surgery. The hard part is doing the rehabilitation afterwards, and that's the most important part. So the contents of what we're going to talk about tonight, we do an overview of what our rapid recovery program is. Overview of our recovery program. We'll talk about normal hip and knee anatomy, and I have over on the table here some pictures of that, as well as some x-rays that we'll go over in the course of the talk. We'll review what is arthritis, what causes people to have a joint replacement in the first place. We'll talk about different treatment options. There are surgical and non-surgical treatment options, and certainly surgery is not necessarily the first option. We'll review what the recovery and rehabilitation programs are, some conclusions, and then we'll give everybody a chance to ask questions. We'll review the educational materials, and that's what's over on the table over here. We have some educational materials. So starting off, what is the 2022 Knox Community Hospital Center of Excellence program? It's a clinical pathway, and it's been developed over time and refined over time as well. But basically, as I mentioned, I keep hitting the wrong button there. Patient education preoperatively, that's a big part of it, so that prepared mind benefits people as far as their recovery process. If you know what to expect, it makes the whole process a lot easier to go through. Physical conditioning, prehabilitation, sometimes we even have you go to physical therapy before surgery to maximize function preoperatively, although that's a balancing act. Sometimes doing too much physical therapy can only aggravate the underlying arthritis condition as well. We talk about nutritional support for healing. You have to have all the basic building blocks for healing: minerals, vitamins, protein. All of those are important, and we use protein and vitamin supplements around the time of surgery. The surgery techniques have been advanced. We use the most minimally invasive techniques that we can. Obviously, you still have to expose the joint. You still have to get down to the joint. But the way that we do that from a technique standpoint is splitting tissue. We don't cut across tendons. We don't cut across muscle. We split tendons and muscles to get to where we want to be. We have wound care techniques that we use afterwards. We have special dressings that we use to try to minimize infection. We are on antibiotics around the time of surgery to minimize infection as well. And then we have a comprehensive aftercare program and follow-up that's discussed, as I mentioned, the preoperative education. We have everything set up for what you're going to do after surgery, actually even before surgery. So that way, like we say, luck favors a prepared mind. I think Albert Einstein said that. So first we want to just kind of go over what's the normal anatomy, what's a normal hip and knee joint. And when you look at the hip, there's kind of a big picture over here that shows the hip is a ball and socket joint. It involves two bones, the pelvis and the femur. And as I said, there's a ball, and then the socket is part of the pelvis or the acetabulum. And that's what this picture here is representing. You can see the pelvis, the femur, and the femoral head. So that's what the hip is, a ball and socket joint. The normal anatomy of the knee, rather than the two bones of the hip, the normal anatomy of the knee is three bones. It's the femur, the tibia, and the patella. So the thigh bone, and that's what the three bones over here, you get the thigh bone, the leg bone, and then the kneecap. So the knee joint, the condyles are the rounded edge at the end of the thigh bone, kind of like a knuckle. It provides the smooth rocking movement, whereas the hip is a ball and socket joint, the knee is a hinge joint. They help distribute the weight of the upper body. When we look at arthritis, the question is, what is arthritis? And it's the loss of cartilage. And the way I like to explain it, you know, when you break open a chicken joint or a turkey joint, it's almost Thanksgiving, believe it or not. You look at the end of that bone, there's a shiny white surface on the end of the bone. That's cartilage. That's the articular cartilage. And that's the rubbery tissue that's found in the joint. It cushions and protects the ends of the bones and provides for the smooth gliding movement on that smooth surface for the bone. So what happens in arthritis is that surface becomes damaged. So what is arthritis? We'll review that quickly here. Arthritis is the breakdown of that cartilage that I just mentioned from wear and tear. And the problem is the resultant joint inflammation and joint pain that results from that breakdown of the cartilage. When we talk about arthritis, there's over 100 different types of arthritis. The exact causes, there's a certain genetic component to it, there's wear and tear. There's other types as well. There's inflammatory arthritis like rheumatoid arthritis. There's metabolic causes of arthritis like gout. And then, as I mentioned, post-injury arthritis. It's not an insignificant problem. 1 in 4 Americans in 2022, there's an extra zero there, 78 million by 2040. The two primary types of arthritis are rheumatoid arthritis, which is an inflammatory arthritis. That's sort of the prototype for inflammatory arthritis conditions. And then osteoarthritis, or wear and tear arthritis. And that's the most common cause of arthritis. Rheumatoid arthritis is less common, as I said. The numbers are here, 1.36 million people in America, up to 14 million worldwide, according to the World Health Organization, 2021. Rheumatoid arthritis affects multiple joints. It's a systemic disease, most likely caused by the immune system, but it is an inflammatory process. That inflammation causes excess synovial fluid. That excess synovial fluid stretches out the ligaments, which then leads to two things: cartilage destruction from the wear and tear of the ligaments not controlling the joint properly, and then also from the inflammation and the swelling, you get the inflammation decreases the nutrition to the cartilage cells, and the cartilage cells can die. So rheumatoid arthritis is an inflammatory form of arthritis. Osteoarthritis, on the other hand, is wear and tear arthritis. It is the most common cause or most common type of arthritis. Currently affects more than 32 million Americans, according to the CDC 2020. It affects women more than men as well, and 62%, 60-40, men are 40%. The hip and the knee are the prime targets, and you say, why is that? Well, that's because we walk on our hips and our knees every day. We don't walk on our elbows or our shoulders, so they do get arthritis, but not as commonly as the hip and the knee. So the numbers, according to the Arthritis Foundation, 2019, 14 million Americans have symptomatic knee arthritis. So as we said, what is osteoarthritis? It's a degenerative disease affecting the joint cartilage. It's wear and tear of the joint. It develops over a lifetime, as I said: use, overuse, injury, repetitive movement, excessive weight, developmental dysplasia disorders from birth. There's, like I said, over 100 different potential contributors to osteoarthritis. The good news, it is a manageable and treatable condition. We have treatments that we can do, both surgical and non-surgical. Just kind of briefly, the symptoms of arthritis, the main thing that brings a patient to the doctor's office is pain. And it's pain from joint swelling, joint stiffness, that makes you limp. Over time, the wear and tear can lead to deformities of the joint, which then affect your activity and your mobility. It starts to impair your lifestyle. When those things start to happen, that's what leads you to see the doctor. So, as I said, why do we go to see the doctor? Because of pain. And there's different tests that the doctor will run. We have to make sure that we have a proper diagnosis so that we can recommend the proper treatment. As part of that, part of the fun that you have when you go to the doctor's office, there's forms to fill out. Those are lots of fun. But that helps us know what your medical history is so we can start to develop an idea of why are there problems and what can we do to help that. A physical examination of the affected joint, and then we get x-rays frequently. So as I mentioned, step one, we get a complete medical history. That's that health questionnaire that nobody likes to fill out, but it's important for us to know what are your health conditions. Do you have heart disease, diabetes? What is going on that can affect our decision-making processes for treatment? So the discussions for treatment with your primary care doctor is usually the starting place. Frequently involves a cardiologist if there's a history of heart disease, hypertension or blood pressure problems, or diabetes. D is decreased range of joint motion. There's going to be tenderness at the joint line, joint deformities. Sometimes you'll see, like we call it a valgus, which is an out knee, or bow-legged, which is a varus deformity of the knee. Those are the different joint deformities that we see. Often you'll see catching, clicking, or popping with movement. That's an indication that you're getting significant arthritis when there's clicking, popping as you bend and move a joint, whether it's a hip or a knee. So the diagnosis of osteoarthritis is based on x-ray findings, and this is just an example, and I have examples up here. I have examples up here in front as well that, there we go. It go from a normal x-ray, arthritis, and then what you end up doing in the end, which is a joint replacement, is kind of the final step in treatment. But just by way of explanation, a normal healthy knee, you can see the joint surfaces are nice and smooth. There's not any chips of bone or calcifications in the joint. There's good space between the bones. Arthritis, on the other hand, is when you get down to bone on bone in the joint. And so what you're going to see with arthritis of the knee, joint space narrowing, that's where it's getting down to bone on bone. Abnormal bone formation, which is the bone spurs that form around the margins of the joint. You can, as I mentioned, the joint deformity, you can get the bow-legged or you can get knock-kneed, either way, depending on which side of the joint is affected more. So arthritis of the knee, it's not subtle. It's obvious, and you can see bone on bone, and you can compare on these pictures as well. This would be the knee x-ray, and you can see, again, normal space versus bone on bone. Same thing with the hip over here. You can see normal space, the ball and socket joint as we talked about, and then with arthritis, it's down to bone on bone. So, having discussed what is arthritis, gone over the considerations that we make in the diagnosis, next step, treatment. So what are the goals of arthritis treatment? Well, whether it's surgical or non-surgical, the goal is to control the pain and other symptoms. So there's different things that we can do. What our objective is to optimize function. We want to keep people in the game. We want to keep, if you like gardening, if you like golfing, the point of treatment is to keep you active. Because we're made to be active as human beings. That's what we do. And so we want to optimize function. We also want to make sure that we give, from an educational standpoint, an idea of what are the treatment options, what type of arthritis do you have, and then what are the things that we can do for it. Bottom line, the good news, there are options to treat the pain. From a non-surgical standpoint, we want to be proactive. We don't want to just sit and let things get so bad that your muscles atrophy, your joints get stiff. You want to come in early so that we can be proactive with our treatment. Sometimes it involves lifestyle changes. There's medications that we use. example of that would be Tylenol or Tylenol arthritis can help pain if your stomach tolerates it and your medical doctor says it's okay to take. Anti-inflammatory medications like ibuprofen or naproxen. There's about 50 different types of anti-inflammatory medications that are on the market that you can take. Sometimes we do injections. There's choices for injections. The one that is beneficial is cortisone, and just about any joint can be injected with cortisone. The knee and the shoulder can usually be done in the office. Sometimes a hip is a deeper joint. Sometimes that has to be done at the hospital. When non-surgical treatment options aren't working, then that's when we talk about what are the surgical options to do to try to restore mobility. And these changes can help your overall health. If you're able to be mobile and up and move, that is good for your cardiovascular health as well. So there's reasons to consider surgery. But as far as the conservative treatments, as we said, 23% of adults have some form of arthritis. The non-surgical treatments involve things that we've discussed: diet, exercise, physical therapy, medications, injections. Nutritional supplements, I get a lot of questions about that. What you're talking about there are some of the options of glucosamine or chondroitin sulfate. Those are not effective treatments of arthritis. There's been at least 20 studies in the last 15 years that show that it's basically no better than taking a sugar pill. So glucosamine and chondroitin sulfate are not effective. Sometimes we use braces. There are different types of braces that are available on the market, from just knee sleeves to hinges. And it's reasonable to try a knee brace. Obviously the hip can't really be braced, but for the knee you can try a knee brace. Walking aids, and what we're referring to there are going to be like a cane or walker. Some patients have walkers that have seats on them, so when they start to get tired or they start to get sore, they can sit down with the walker that they have. And rest and ice can be helpful. If you're up and walking and things start to get sore and you just stop for a minute, just stop for 60 seconds and rest and then go again. Sometimes just taking a brief rest can help. So those are the non-surgical treatment options to think about. From a surgical standpoint, the question is, when should a total joint be considered? And the things that we look at: is pain negatively affecting your daily living? Is it preventing you from doing the things you enjoy doing? Is it keeping you awake at night? You've tried some of those other things that we've talked about. You've tried heat, ice, rest, modification of activity, medications, bracing. When those types of non-surgical treatment options are failing to provide adequate relief from the symptoms. The x-rays, we don't do total knee or total hip replacements on normal appearing joints. That's not why you're having pain. Unless there's significant arthritis changes on x-ray, you have to look other places for why are you having pain. And there can be soft tissue injuries, there can be nerve compression, there's other things that can be contributing to joint pain. And so you want to make sure that the indications are there regarding the specific diagnosis of arthritis. What are the benefits of joint replacement surgery? Can eliminate or reduce joint pain. Not everybody gets 100% relief of pain after a hip or knee replacement, but probably 50% of people get complete relief of pain. Probably 47% of people get near complete relief of pain. The results are good. It will potentially enhance movement and mobility. You know, if you can move around easier, you can be more active. Improving quality of life for the same reasons. Return to more normal activities, get back to doing the things that you want to do. And as far as normal activities, there are some considerations as far as sports and activities. After a knee or a hip replacement, one of the things to kind of know how long it's going to last depends a little bit on how you use it. And so low impact activities are good. Higher impact activities, running, jumping, twisting, those are things that, just like you wore out your hip or your knee to begin with, you can wear out a hip or knee replacement as well. So there are limitations. From a total joint replacement, whether it's a hip or a knee, what does the surgical procedure involve? And basically the damaged bone is resurfaced, and the metals are biologically inert metal alloys with a polyethylene spacer. The way to think of it is like capping a tooth or retreading the joint surface. It's not like you're removing the joint. You're just shaving off the area where the bone is going bad. And what I mean by that is just to, by example, that's what these things are here. Just to kind of show you, for example, with the knee, if you look at the knee from the side, you can see we're not removing the whole end of the bone. All we're doing is shaving off just the specific part that's gone bad. We clean off the arthritis, and then we cap the end of the thigh bone. Same thing with the top of the leg bone. We're smoothing that off and then capping it. There's a metal cap, and then in between goes the spacer. So instead of grinding bone on bone, it allows it to glide smoothly again. So the concept of what we're doing is not replacing or removing the entire bone. We're just shaving off where that bone has deteriorated. And as I said, it's similar to retreading a tire or capping a tooth. So for the knee replacement, there's three components. There's the cap that goes on the end of the thigh bone, the cap that goes on the top of the leg bone, the spacer that goes in between, and then there's also a cap that goes on the kneecap. So for the knee, there's three pieces: the femoral component, the bearing surface, as I mentioned, and then the tibial tray, and then the kneecap. For the hip implant, it's a little different. The hip is a ball and socket joint, but it's the same kind of concept. And the socket, as we said earlier, that goes as part of the pelvis. So we're shaping the pelvis and we're shaping the proximal femoral component. We're putting a new ball and socket in there. So there's kind of three. There's the femoral component, there's the socket, and then again there's the bearing surface. So instead of grinding bone on bone, it allows it to glide more smoothly. Just sort of parenthetically, one of the other things that we do is a partial knee replacement. Sometimes if the knee is only degenerated in one spot, like the inside part of the knee, rather than replacing the whole knee, we can just do a partial knee replacement. The results of partial knee replacement are as good as total knee replacement in terms of longevity, how long they last. The results are similar. The bottom line, when you take care of where the arthritis problem is, that rebalances the knee. The other parts of the knee are no more likely to go bad with a partial knee replacement than you are to wear out a knee in a total knee replacement. So that's the surgery part. What do we do afterwards? Well, after surgery, there's a couple of things to know. We talk about this in the office before surgery, and there's how we get back on our feet afterwards. The bottom line is we get you up even the day of surgery now. So it's not a situation where we let you just stay in bed and get weak and you don't have exercises to do. We get you up the day of surgery. So a couple of things. What allows us to do that? So our advances in medical technology, we have improved instrumentation. There's less trauma from the surgical procedure, as we alluded to. One of the things that has improved significantly over the last 10 years is our anesthesia techniques. There are better anesthesia medicines that we use, so there's fewer side effects from the anesthesia. We also do regional nerve blocks, so we don't have to use as much anesthesia. So that leads to hopefully less pain after surgery, and then a faster recovery, because if you're not drowsy and asleep after surgery, you can get up and get moving right away. And that's our goal, is to get you up even the day of surgery. The bottom line, it leads to a faster recovery because you need less pain medication. That helps our outcomes be more predictable and acceptable. So the joint replacement surgery, Depending on the amount of deformity, the incision is going to be 6 to 10 inches. The knee incision is over the front of the knee. The hip incision is on the side of the hip. We have to be able to see what we need to see to take care of the deformity and make sure that we get the implants in properly. The surgical technique, the minimally invasive techniques that we use, we have special positioning that we use, we have specialized tools, and the implants that we use are the same implants that have the proven track record. The advantage of the robotic instrumentation that we use is that we don't have to violate the canal of the bone. So the cuts, the robot helps us with our computer navigation get the cuts made so that we don't have to put our alignment rods inside the bone to get the cuts where we want them. So with the surgery being less invasive, there's less blood loss, you get back on your feet faster. So what is robotic navigation? We get x-rays of your knee in the office, obviously. The robotic navigation is covered by insurance and Medicare. It's just part of it. For us, it's just another tool in the toolbox. We use it as part of the procedure. There's no extra charges or anything for that. What the robot system does is it creates the cutting guide position on the bone. The surgeon is still doing the work, obviously, but it helps us get our alignments where we want without having to violate the canal of the bone. It also allows, as we do the sizing before we start the surgery, and as we get our alignments set, it gives us an idea of what the size is going to be even before we start the surgery. And I didn't bring my handout that shows what the different sizes are, but basically for the hip, everybody's worried, well, do you have the size that fits me? And we have, for the hip, about every 1 millimeter in size for sizing of the stem, the ball, and the socket. For the knee, we have sizing that's about every 2 millimeters. So we can accommodate the smallest of the small and the biggest of the big with our size that we have to use. So the size is not a problem. We have multiple choices there. The robot, as I said, it allows us to use a less invasive surgical technique. What are the benefits? It does not add any additional anesthetic time. It allows for less blood loss, as I said, because we don't have to violate the canal of the bone, so there's less bleeding as part of the surgery. Because we know what our sizes are going to be, we have less instruments on the table to do. We know where we are. It allows for shorter hospital stays because the surgery is less invasive. People can get back on their feet quicker. The bottom line is less cost for the hospital and the patient. So it's advantageous on a number of levels. What our minimally invasive rapid recovery system, what it has, the implants, as I mentioned, we use the same technologically advanced implants in all hip and knee procedures. As I mentioned, the implants are available in many sizes. It's not one size fits all. We have sizes to fit different people. Traditional surgery requires a more lengthy recovery. It's slower to get up. The muscles and tendons don't heal as fast. From a surgeon standpoint, we understand the need to help patients heal quickly. We know that patients don't want to spend extra days in the hospital. We know that we want to facilitate getting back to the things that you want to do as an active, productive lifestyle, whether that's back to work or back to recreational activities. So a review of the advantages that we just mentioned, robotic navigation, less tissue trauma, so earlier restoration of function of muscles and tendons. There's less scarring, less pain, less blood loss, and shorter hospital stays so that we have a more rapid recovery than from traditional surgery. So, kind of going through what are the benefits, pain relief, restoration of function, getting back to activities. There's always risks, there's always benefits, and we talked about the benefits. So some of the possible risks of joint replacement, different things that we have to mention, infection, a couple of things that we do. We have the same infection prevention techniques that any hospital that does joint replacements has. We have a rapid air filtration room that we do our joints in that has ultrafiltration of the air. We use antibiotics around the time of surgery appropriately. That helps decrease the risk of infection to less than 1%. Blood clots or phlebitis, deep vein thrombosis, those are all synonyms, but blood clots, the risk of blood clot is less than 0.5% with the blood thinners that we use. Some patients come in, you might already be on a blood thinner. We sort of risk evaluate a person as to what the risk is as to what we use for the blood thinner. Some patients are already on a blood thinner like Coumadin or warfarin or Eliquis or Xarelto. Other patients are on blood thinners for their heart disease like Plavix or aspirin. The more recent studies show a couple of things. Number one, we no longer have to use the injections, which was the Lovenox or enoxaparin. There's pills that you can use, and the choices with pills, the studies show that actually aspirin works as well as Xarelto for prevention of DVT and pulmonary embolism. So the bottom line, if a person's able to take aspirin, we can adjust your aspirin dose. The prophylaxis for blood clots, the prevention of blood clots, you're on the medicine for about 4 weeks after surgery. So that just depends on what risk level you are as to what medication is chosen for that. But frequently we use aspirin if a person's able to take aspirin now. Pneumonia is actually the most common potential complication. That's 3%. And that's across any orthopedic surgery, and that's just because of the fact that you're laying down for a while and the anesthesia agents sometimes affect your breathing for a short time. The bottom line, we have, it's called an incentive spirometer. We actually have a little toy that you use to breathe and take deep breaths so that you're coughing up the crud. Patients who have chronic obstructive pulmonary disease, asthma, are a little bit higher risk for pneumonia, and we pay attention to all patients, but a little more maybe with those particular problems. Implant breakage, longer term risk after surgery. What are the outcomes? Unless you're unlucky and you get an infection or you fall and break the bone around the knee or damage the implant, 10 years after surgery, 97–98% of patients are still doing well. 20 years after surgery, there's about a 1% per year drop off after 10 years. So after 20 years, still 80% are functioning well. Of course, we also think that the implants that we were putting in 20 years ago, I think we do a better job now than we did then. So that's what that refers to, implant breakage or falls, like if you're in an accident or you fall and damage the bone around. Technical problems, those are reduced with the use of the robotic navigation. And then premature wear, again, overuse, as I alluded to. Jack Nicklaus had a hip replacement done back in the 90s, and he tried to go back to playing competitive golf. And within 6 months, the twisting and torsion loosened the implant, and he had to have it redone. And so that's what I was mentioning as far as like the activities, low impact activities. Bo Jackson did the same thing. If you remember, he had a stress fracture of his acetabulum when they were playing the Bengals. He went on and developed avascular necrosis of his hip and had to have a hip replacement. He tried to go back and play baseball after that. It didn't work. You can't play at that level. You can get back to recreational, low impact activities, but that's what we're referring to as far as overuse. So a review of the steps as far as our rapid recovery, minimally invasive process. Preoperative conditioning and strengthening exercises, prehabilitation, nutritional support for better health during the time of surgery. We put you on protein supplement, multiple vitamin with iron, so vitamins, minerals, all of those. Paying attention to, if you want to heal rapidly, you have to have the building blocks for healing. And so we pay attention to that. The robotic technology in the knee, the robotic technology does not work for the hip, but for the knee we use it. And then the aftercare program focuses on your wellness and quick return to activities. So typically, how does it work? You're in the hospital stay of 1 night. We do occasionally, if you meet certain criteria, it can be done as an outpatient. We talked to you about that before surgery. The choices are kind of going home with home health care, or you can go to a rehab facility. We talk about what the pain management is. Basically what happens before surgery is When we see you in the office, and even before you go to the joint class, as we talked about, you actually get a handout. There's a booklet to read through that goes through all of the different things that we just mentioned. We actually have a full-page handout about pain management, do's and don'ts for after surgery. So all of that is important as far as getting you back on your feet afterwards. The physical therapy we mentioned, and then the supervised physical therapy for 4 weeks. You can do that through home health or even outpatient, depending on how you're doing and what your preferences are. Care, we mentioned you have kind of two choices, home health care or skilled care facility. And then everybody wants to know, when can I get back to doing things? And some of that depends on whether it's your right or your left lower extremity as far as getting back to things like gardening. But typically, as I mentioned, we get you out of bed even the day of surgery. You get back to routine activities within 2 to 4 weeks. You progress after surgery. Most patients will start off with a walker, and you progress to a cane over the first 2 to 4 weeks. And then eventually, when your balance is good, you can get back to just walking normally. Driving, gardening, shopping, 6 to 8 weeks usually for driving. What I mentioned to patients is you have to be off of pain medicine because you can't drive under the influence of pain medicine. And you got to be able to get in and out of the car easily and safely. So there's turning and moving. And then you got to be able to step on the brake so that you can stop so you don't hit someone or something. So the right leg is usually a little bit slower maybe than the left one. So as we talked about, what are the activities you can go back to? Low impact activities, usually by 8 weeks. You can get back to doing low impact activities, just as a reference, like golfing, dancing, bowling, swimming. We like to keep people out of the swimming pool for at least 6 weeks after surgery so that minimizes the risk of any wound problems. You got to make sure the incision is completely healed before you immerse it in water, like a swimming pool, hot tub, sauna. One of my patients asked me about hot yoga the other day. So those are the things to kind of think about. You don't want to sweat on your fresh incision. Are there restrictions? I alluded to that earlier. Running, jumping, twisting, turning, I gave you some examples of what can happen if you try to do too much. It is possible to wear out, just like you wore out your first knee, you can wear out your second hip or knee. What we usually talk about with return to work, U.S. Department of Labor has different classifications. There's sedentary, light, medium, and heavy duty work. Heavy manual labor, definitely restricted. That's unlimited lifting. We usually limit, depending on the person and their physical attributes, we really don't want you lifting more than 20 or 25 pounds, no climbing, kneeling, crawling, kinds of things. So that basically meets the light duty description of labor from the U.S. Department of Labor definition. So after surgery, when do you follow up with your doctor? Usually 1 or 2 weeks for an incision check. Then at 4 weeks, we get an x-ray, make sure everything's healing okay. At that point, depending on how a person is progressing, we set the schedule for the first year. Longer term, we like to check once a year. I might see something on the x-ray before you'd feel it in your joint. So the bottom line, regular checking of the joint assists in preventing complications. I might see something on x-ray before you would feel it in the joint. And what we mean by that, if you look at, I'll just use the knee as an example. One of the things that I'm looking at, I'm making sure that the bone is reacting properly to the knee all the way around, but also I'm checking that spacer. And the bottom line is you can change that spacer out, and that's a lot less surgery than redoing the whole knee. So if that spacer starts to show signs of wear, you can replace just the spacer. And that's true for the hip or the knee. So in conclusion, proper diagnosis can help you identify the cause of your joint pain and allow for proper treatment. You can see an orthopedic surgeon such as myself for diagnosis and consideration of what the treatment options are. The first choice is not necessarily surgery. There are other options. And should surgery be necessary, the rapid recovery program may be beneficial for you. We have worked hard over the last 10 years to make sure that we have the proper program in place for our patients. So thank you for listening, and we wish you a rapid recovery, should you need surgery.